Well, good morning, everybody. While you're getting to your seats, just a couple of items here. I want to first thank a special thank you to our partners here at NYU. They've been, again, tremendous hosts, and we appreciate all of their efforts. Also, special thanks to the team led by Kristen Eicher to plan the program and get everything pulled together today. We really appreciate that. Also, a special thanks to Melissa Carr, who was unable to be here today, from Stony Brook, who was fantastic in helping us organize what's going to be a tremendous day today with presentations from staff from that institution. I also want to welcome our remote guests, members of the Scientific and Technical Advisory Committee, and community and researchers that are joining us again remotely. And we hope to see all of you at some point in the future. I also want to thank, and a special thanks to all of the researchers, the researchers who continually display an amazing amount of dedication and creativity as far as World Trade Center research is concerned. We have a splendid program today. The researchers that are on the program that you will hear have published collectively over 60 World Trade Center related research publications on a variety of topics. And they also have authored and gotten funded over 25 very high impact studies of various World Trade Center outcomes. And we're delighted to have them, with us today. Another thing that I want to do, we have a special opportunity today. We have with us Dr. John Howard, who's going to introduce our new Associate Director of the World Trade Center Health Program, Captain Lisa Delaney, that maybe some of you haven't had a chance to meet. And I want to give, some of you certainly no introduction is needed for Dr. Howard, but some of you, particularly our early career researchers and mid-career researchers, may not be as familiar. And so I want today, it's important for me to give you an introduction to him. Dr. Howard, of course, is the director of the National Institute for Occupational Safety and Health and is the administrator of the World Trade Center Health Program in the United States Department of Health and Human Services. Dr. Howard was first appointed NIOSH director in 2002 and has served in that position. He did serve in that position until 2008. In 2009, Dr. Howard worked as a consultant with the United States Afghanistan Health Initiative. And in September of 2009, he was again appointed NIOSH director. He was reappointed for a third 6-year term in 2015 and a 4th-year term in 2021. And prior to his appointment as the NIOSH director and the World Trade Center Health Program administrator, he served as chief of the Division of Occupational Safety and Health in the state of California's Labor and Workforce Development Agency. And that was from 1991 through 2002. Dr. Howard earned a doctorate of medicine, a master's in public health, a doctorate of law, a master of law in administration, and a master's degree in business administration and healthcare management. He is a board-certified internal medicine physician and also is board-certified in occupational medicine. And he is also a member of the United States Supreme Court Bar and has, of course, written numerous articles on occupational health policy and law. And I'm delighted to be able to introduce him today, and he will introduce Captain Delaney, who we're delighted and very pleased to have with us. Welcome, Dr. Howard. Thank you very much.
Thank
Nice
you.
to have you.
Thank you. Thank you, Travis. I appreciate the introduction and welcome to our semi-annual research meeting. Hopefully you can hear us. Want to thank NYU for their tremendous support. Really a great shout out to all of you. Thank you so much. Welcome to all of you in the room and also online. Thank you for attending. And I also want to say what Travis said. Thank you to all of our researchers. Without you, World Trade Center Health Program research could not go forward, and we certainly could not have a meeting to discuss our research. So thank you very much. As you know, research is a tremendously important component of the health program. The Congress recognized through stakeholder input that we need to learn more about World Trade Center related health conditions, and also how best to care for responders and survivors who suffer from World Trade Center related health conditions. So again, thank you to all the researchers, and I look forward to hearing about your research today. So my job this morning is to introduce our new Associate Administrator for the World Trade Center Health Program, Captain Lisa Delaney. And I'm going to invite her to the podium because I'm going to ask her to tell you about herself. We're just really delighted after an intense search and many qualified candidates that we found the best person right here at the National Institute for Occupational Safety and Health. Lisa is going to be a great addition to our program, and I'm delighted that she's there with you today. And so I'm going to bow out and wish you a wonderful day, turn you back over to Captain Lisa Delaney.
Great. And thanks, Dr. Howard, for joining us, and thanks, Travis and others, for pulling this meeting together. I know it was a lot of work to get everyone in the room, and so thank you all for being here today, and those of you who are here virtually. So I don't want to take up too much time talking about myself because the important work is hearing from all of you, but I am new to the program, but I'm not new to NIOSH. I started in 1999 in a fellowship position, so I was a fellow when 9/11 happened and had ideas of going into the private sector, getting my feet wet, learning about how to be an industrial hygienist at NIOSH, and then going off to the private sector. And then 9/11 happened, and that really changed the trajectory of my career. I was in Atlanta in a makeshift emergency operations center helping to deploy. There are very few NIOSH staff based in Atlanta, so I was one of a handful of staff that were helping coordinate our NIOSH efforts and deployments of staff here. And that really changed the direction of my career. Eventually, I joined the Emergency Preparedness Office, which didn't exist until after 9/11 when we started to improve how we coordinated and responded to emergencies. And the focus, of course, in our program was to protect and issue guidance and plan on how to protect responders. And we defined responders broadly. So I did that for 18 years, everything from Deepwater Horizon, lots of anthrax, ricin responses were always very quirky and fun, and of course, Ebola and the pandemic. So, at first when I thought about this job, I thought, why me? But now that I've joined, I really see the connection between emergency preparedness and the work that we do here. It's fast-paced. You need to be a quick study. So I think that my 18 years in emergency preparedness really actually prepared me for this job. So I'm really thrilled to be here. It's an important work, and I'm just thrilled to hear the important research. And I echo Dr. Howard and Travis's comments that it's really important, the work that you're doing, to help us improve how we provide care for our members, and this collaboration and coming together is critical to help build that bridge between the extramural and the intramural work. So with that, I'm going to hand it over and let us start the sessions. Thanks, everyone.
Good morning, everyone. I'm Kristen Eicher, if you don't recognize my face yet. I'm going to get my slides up here. So you can follow along with the meeting today by scanning this QR code. It's also printed on the cover of your program. You may also notice that some of our presenters also have a QR code on their introductory slide today that'll show up here. And for that meeting, for this meeting, we've asked our presenters to recommend articles that help attendees gain further insight or context to their presentations. So for convenience, those are located on the link that QR code leads you to. And we hope that this really enriches your learning experience today and provides a new layer of engagement with your colleagues at the research meeting today. I will now turn it over to Max Lum. He's going to be our MC for today, and then he will introduce our opening presentations.
It's good to see everybody. I hope you had a couple good months and are back with us. It's great to see everyone. So, coming up here on the train, I thought, you know, what we need for this meeting is a tagline. So, for this meeting, I'm just stealing Home Depot's tagline, which is, how doers get more done. So today we've got a series of doers that's going to talk to you about their work. And they're going to talk more about not just the how, but the what. And most importantly, I think, for our transitional research approach, is the why. And I think to that end, the folks at NIOSH, the research team, the group, has provided the researchers a list of questions that will help focus their research presentations on the how, the what, and the why. So we'll be listening for those answers to those questions. And I think we'll have an opportunity, hopefully, to take a few questions after each presenter, but I think it really depends on our time. So the first speaker, Leonardo Trisande, is well known in child's environmental health. His research focuses on identifying the role of environmental exposures in childhood obesity and cardiovascular risks, and documenting the economic costs for policymakers of failing to make the recommendations, the preventive recommendations suggested. He holds appointments at the Wagner School of Public Service at NYU, College of Global Public Health. Dr. Trisande leads one of the 35 centers that NIH has funded in childhood outcome study. He is principal investigator for a research project comparing neurodevelopment, cardiometabolic, and respiratory profiles of children exposed in utero to World Trade Center disaster to a comparison group. Leonardo, please.
Good morning, and thank you, Max. Thank you to the organizers. This was not a hard commute for me in terms of my academic home. I'm delighted to be revisiting a topic and trying to project forward about where NIOSH should be investing its future research, particularly around the theme of a youth cohort. And I'm honored and delighted that my colleague, Dr. Julie Herbstman, and I will be tag teaming this presentation. I'll be starting for about 10 or 15 minutes, providing a broad overview of what we know about exposures that occurred on 9/11 and what we do and don't know about the consequences, particularly for the young adults who were exposed in that early era. Before I go further, though, just some disclosures in that I have written particularly a book for lay audiences around the effects of endocrine disrupting chemicals on people's lives. So insofar as that's a potential financial conflict, it's on the table at this point. Now, when we think of the dust that was emitted on that fateful day and in the months that followed, we typically focus on the particles, but there were a diverse array of chemicals that were released as well, which have varying half-lives, some of which are still detectable and have been detected in epidemiologic studies years later. I'm going to just review what we know about the state of chemical exposures from a variety of subpopulations. First, I'm going to talk about the firefighters who had blood collected along with urine very early on. This was a state-of-the-art at the time and very broad suite of chemicals that were detected, and prominent in the exposure profile was at least one dioxin as well as PHs and antimony. Antimony is important because it's a flame retardant used in plastic, and you can imagine in the towers there was a very large amount of plastic, much less so than would have been had such a disaster occurred today, but all the same, a very important exposure to consider. We didn't have the capacity back then to measure microplastics in the way that we do now, and that could be an area for future research in particular. We also know that responders had higher PFC levels, perfluoroalkyl substances, nonstick chemicals used in oil and water resistant clothing, as well as nonstick cooking materials. And there were associations related directly to the degree of dust and smoke exposure. Now, my colleague, Dr. Herbstman, described one of the very earliest measurements of early life exposure to contaminants in World Trade Center exposed populations. And she and her colleagues found that brominated flame retardant exposures were substantial along with mercury, but not as consistently as one might expect in relationship to the exposure. There was a higher level of PBDEs in women whose second half of pregnancy did occur on 9/11. It's important to emphasize that Americans in general between 1975 and 2013 have historically had some of the highest brominated flame retardant levels in the world because of a requirement that flame retardants be added to polyurethane foam. So there's a very high baseline in which these incremental exposures may have coexisted. Now, moving along to other biomarker studies of World Trade Center community-based populations, we measured dioxins in adolescents who were exposed to the disaster and compared them to a matched comparison group, and often and found associations that were very strong, differentiating the two groups, and with the World Trade Center exposed group having much higher levels than even the 95th percentile from the National Health and Nutrition Examination Survey. These exposures were lower than some other environmental disasters that involved dioxins, but were still quite substantial. Moving along to another follow-on study of that same population, we identified some higher PFAS exposure in adolescents compared to comparisons, though compared to historical population representative samples, we did not see a change in compared to, we saw lower levels actually compared to National Health and Nutrition Examination Survey data. In a companion study looking at earlier life exposure, we did see some substantial differences in PFAS levels based on proximity. This is again in collaboration with Dr. Herbstman, and with an association that was stronger, not just particularly for those who lived, regardless of their work location. Earlier, Mary Wolf and colleagues had done a smaller scale study of pregnant women who lived near the World Trade Center site. They had not measured PFAS in that particular study, but did identify a number of significant associations with a broader suite of chemicals, including polychlorinated biphenyls. And they did also see dioxin at higher levels in similar, by the way, to World Trade Center exposed firefighters. And then Pereira and colleagues also identified PHDNA adducts in a substantial relationship to proximity to the World Trade Center disaster site and showed an interaction on cognitive outcomes in relationship to the pH DNA adducts together with markers of in utero tobacco smoke exposure. So to summarize all of this evidence in rapid fire, I've put together some tables, and there are as many gaps as there are holes filled in our knowledge of exposure to the disaster. There are things that we can impute, a consistent theme that we can perhaps tease out is dioxins as a biomarker of World Trade Center exposure, with PFAS being a close second. It's important to emphasize that this many years out in the disaster, we're probably a couple half-lives into PFAS exposure, whereas dioxins were still in a window where we could measure and evaluate the exposure. This slide further provides it in plainer English, what I already had described. There are some limitations to the available studies, particularly the low sample size. But moving on from there, what are the health consequences of these exposures? We knew back in 2001 that there were consequences likely for neurodevelopment, cancer risk, as well as respiratory irritation from World Trade Center dust exposures. The new knowledge that has emerged since 2001, and that's not a byproduct of World Trade Center research per se, but it's a broader scientific understanding, is that these exposures can also hack our hormones, our natural signaling molecules that underlie basic biological functions, from temperature, metabolism, to salt, sugar, and even sex. This has been described in two Endocrine Society scientific statements, 2009 and 15, a World Health Organization United Nations Environment Program report documenting a global public health threat posed by EDCs, the American Academy of Pediatrics statement on food additive chemicals, as well as a very recent National Academy of Sciences statement on PFAS exposure, which is now understood to contaminate the water supplies of over 100 million Americans. And these chemicals are now so well recognized as obesogens that we appreciate the need for policy interventions to take away the background of many of these exposures that are known to exist, besides the acute increases that can arise through a disaster-related event. Now, that doesn't preclude a need to consider what are the long-term consequences some many years after September 11, 2001. And in particular, when you're looking at youth-exposed populations, we appreciate that exposures occurred likely during multiple stages of development, but the consequences are continuing throughout the life course. And you can see a list on the far right, the potential outcomes that might be related. I'm just going to take another minute or two just to go over what we know in specific about World Trade Center-related chemical exposures and chronic diseases. We know, for example, that obesity, diabetes, and cardiovascular outcomes are substantially related. And then we also know particularly infertility and reproductive outcomes are exquisitely vulnerable. We know particularly the most about male factor infertility related to these outcomes, but an emerging body of evidence suggests that ovarian function and uterine function can be directly related. This is from the Endocrine Society's second scientific statement, and depending upon the phase of follicle development, you can see different chemicals having different potential consequences. And it's not just effects on uterine and reproductive tract development that are important. The hypothalamic pituitary axis is also terribly important in thinking about the consequences for reproductive health. And what we know from other studies already suggests consequences for puberty among particularly dioxin and PFAS exposures. These are data coming from the West Virginia large-scale cohort that unfortunately was near a prominent water contamination site. And in the context of dioxin-related disasters, we know that endocrine-related cancers are well documented, be it from Seveso as well as related to PFAS consequences in northern Atlantic populations. So we appreciate that we're not going to be able to recreate samples that were not collected back in 2001, 2, and thereafter. Are there ways that we can leverage the state of the art to better understand what are the consequences of World Trade Center disaster exposure? And the good news is that yes, there is this notion of the exposome developed by Christopher Wilde in 2005 that really provides a broader perspective in which chemical exposures sit and emphasizes the need for technological developments to help us understand biomarkers that may be intermediately related to exposure and contributing to disease and disability. That together with biomarkers of chemical exposure can help us put together the puzzle. We can use existing cohorts and samples and populations, and I, as a community researcher, I'm not ruling out the need for considering responder populations as part of a broader effort to really help us understand the consequences of chemical exposures that may benefit all populations across the lifespan. So if you've already, if you've been listening, you can understand that my emphasis in particular, my suggestion for the field moving forward is a focus on endocrine related conditions. And there are opportunities to study interventions in particular. I'm very much cognizant of the lifestyle medicine RFA that allows us an opportunity potentially to modify endocrine-related conditions. And I'm also cognizant there are other coexisting environmental contaminant exposures that may magnify effects in World Trade Center previously exposed populations. So with that, I want to be cognizant of my time and pass the baton to my colleague, Dr. Herbstman. But I hope this is another opportunity for us to emphasize a need to incorporate stress and post-traumatic stress in particular as an important contributor to World Trade Center related exposures. But and there's a dearth of our understanding with respect to chemical exposures and an opportunity for action. So thank you very much.
Our next speaker is Julie Erbston's research, and it focuses on the impact of prenatal exposure to environmental pollutants, including child growth and development. She has been involved in research exploring the long-term environmental health impacts of exposure to pollutants from the collapse of the World Trade Center on 9/11. She's director of the Columbia Center for Children's Environmental Health. Julie?
Great. Thank you so much for having me here. It's nice to be with you all today. And it's super easy to follow Dr. Tresande's presentation, because what I'm aiming to do today in the next 10 minutes or so is to give you a taste of how we can use expanded tools in molecular laboratory science and molecular epidemiology to try to understand better what folks were exposed to, and also potentially what the impact of those exposures might be and what we can anticipate. So I want to start by saying that this work was conducted largely by a postdoc in our group, Vrinda Kalia, so I want to make sure to acknowledge that up front. So I don't think I need to spend a lot of time. Leo already discussed what we understand in terms of exposure to chemicals that occurred as a result of the WTC tower collapse. What our group has done is really we recruited individuals who are pregnant on 9/11, and then we followed those pregnancies through and were able to collect a number of biosamples that we have stored and follow the children as they grew. And so there are a number of publications that Leo presented already acknowledged the different chemical targets that we looked for and some of the health outcomes that we expected. And so one of the compounds that he highlighted was the fact that we found higher levels of perfluorinated compounds in umbilical cord blood of pregnant women who were exposed, who were pregnant on 9/11. And that's important as we follow these people forward to try to understand what is the impact of having these compounds found at high levels in cord blood. We also have published, again, some of the things that he's highlighted already, associations with birth weight, neurodevelopment, and probably most recently on lipid metabolism. And that's a health outcome that we have recently learned is associated with perfluorinated compounds, PFCs, PFAS, however you'd like to abbreviate it. So this is the context that we're working in. We have these stored samples, and we've analyzed a lot of them for targets, analytic targets that we think were present in the dust, in the smoke. So we are going after what we know, right? And so what I'd like to leave you with today is that there are health effects that we probably don't understand very well and exposures that we don't understand. And is there a way to leverage these new tools like non-targeted analyses to try to help us understand what we don't know? And so what we're trying to do here is leverage samples that we've collected in 2001, 2002 that have been stored now for 20 plus years, and use those stored samples with this new technology so that we can try to understand essentially two things. Can we see the exposures that we expect to see? Can we identify exposures that we didn't know to look for, right? And can we try to understand what are the molecular impacts of those exposures? And so to answer all those three questions, we can use these non-targeted analyses or metabolomic analyses to try to get us closer to those answers. So these are the two questions that I'd like to try to address in 6 minutes. First, take a look at what exposure, what chemical features can we find when we look at people who were exposed and compare them to people who were less exposed. And then what do we know when we have a target like perfluorinated compounds, what are the metabolic features that associate then with that exposure? So the tool, again, we use is a mass spec, an Orbitrap mass spec, and I won't take you through all the details, only to say that through the cores that we have access to, we can use these techniques to try to understand the chemical spaces, both exogenous and endogenous. Again, I think I spoke about this already, but the first study that I'm looking at here is we compared in a pilot space extremes. So we had women who had dust from the towers fall on them while they were pregnant, and we view these as our most exposed people. And then we had people who were exposed, but dust did not fall on them. And so now we're using these two populations to try to understand what are the features, what are the chemical features that can distinguish the exposed from the unexposed, although I will say unexposed is not really unexposed in this case. So we use a supervised dimensionality reduction technique, PLSDA, to try to separate the two groups. And once we separate the two groups, we can try to understand what is the composition of these features, right? And so the top 5 features I'm showing here, once we map them from the mass spec, we can basically map them to libraries. And so we try to figure out, well, what are these peaks? What do we know about them? Sometimes they map to targets that we know. In this case, the second, third, fourth, and fifth map to these known targets. The highest peak is something that is unidentifiable. So we will have to do more more detective work to try to figure out what that actually is. It's annotated as a fluorinated molecule, and we need to know a bit more. Once we have those targets, we can put them into a pathway software to try to understand what are the health effects that we might be looking for in people who have high exposures to these chemical features. And so in this first analysis, we see that energy generation, fatty acid metabolism, as well as vitamin metabolism are likely impacted by exposure when comparing these highly exposed individuals to those who are less exposed. So this is just a quick summary of what I just explained. Now moving on with 3 minutes to what might we expect following exposure to perfluorinated compounds in cord blood. And so now, instead of looking for other exogenous features, I'm turning inward to say, what can we understand about endogenous features? So if we compare people who have high exposure to perfluorinated compounds to people who have lower exposure, what can we learn about this using the same techniques? So here we have when we measure perfluorinated compounds using targeted analysis, we have somewhere along the lines of 6 to 10 perfluorinated compounds that we can look at. We use PCA to reduce the number of dimensions, and in our first principal component, it basically is a high exposure to 5 of these compounds. And when we look at the features that are associated with having high exposure to perfluorinated compounds, we see 2 features pop out. One of them is actually another perfluorinated compound, which is actually good, right? We're happy to see that this is what we would expect to see. It's a metabolite likely of PFAS, and something we can try to understand. The second feature is something that we don't understand yet and need to do more detective work on that. When we look at the second principal component, this one is a little bit more mixed. So then rather than representing high exposure to all of the perfluorinated compounds, this is high exposure to PFNA and PFDS, which is, is high exposure to PFOA and PFHXS. We can try to understand what happens when you have high exposure to just those 2. Right, and not the others. And we have, after adjusting for multiple comparisons, we see a number of features pop out that we need to then understand. So we can put those again into our pathway software and try to understand what is the impact of having high exposure to these compounds. And we see again this association with lipid metabolism, vitamin C, and xenobiotic metabolism. Again, this is interesting. It tells us both what we should be looking for metabolically, what we should be looking for in terms of targets, and then potentially what health outcomes we should be worried about. So again, this is sort of the conclusions to the second question I raised. Here, trying to understand what are the metabolic features that we can expect to see following exposure to perfluorinated compounds. So just to sort of wrap up, maybe I'll skip this overall, but talk about the next steps. So where are we trying to go with this? For one, I was trying to demonstrate that we can use these stored samples that have been stored for 20 plus years, using these new techniques to try to help improve our understanding of what exposure occurred and what outcomes we might expect to see. I think it's important to note that a lot of the targeted analyses that we did were done in 2001 when the techniques had higher detection limits. You needed bigger quantities of biomatrix in order to get any kind of result. Now we're at a different space where we can use smaller volumes to get more information. And so we're in the process of expanding our results. I spoke to you today about the LCMS, the liquid chromatography. We're now also running the same samples using gas chromatography. And the idea here is that by using the LCMS and GCMS, we can get we can cover a larger space of features to try to understand both the exogenous and endogenous effects of WTC exposure. So I think I'm a little bit over time, but just again want to really acknowledge Frunda for her hard work and the rest of the team here who's been working on these metabolic analyses. Thank you.
Stay there. Take some questions. Questions? I have a quick question, and that is, has there been any plans or strategies related to looking at other organizations that have collected data related to the exposure either. And do they exist?
I mean, I guess I would just say I don't know of that many that exist. If there are folks or anyone knows of folks who have stored samples that we can go back to, obviously the techniques we're using are tolerant of samples that have been stored for a long period of time. It does depend on how they've been stored, but that's where I would begin. But offhand, I don't know of any other groups. Maybe you do.
I don't have anything to add, sorry.
Hi, Dave Prezan. Very interesting study. So you've got some biomarkers, and you've got non-World Trade Center research using your health outcomes application modeling to predict that there would be lipid disorders that we would see in this group. This group now is roughly 22, 23 years old. Has there been any acknowledgement or surveys of diseases, especially lipid-related diseases, in the cohort that you actually have access to, the studies, the bloods that you actually have?
Thank you for the question. Our sample sizes are relatively modest for the kinds of outcomes that you're talking about. You'd really need odds ratios of 4 or 5 to really ask that particular question from a clinical perspective. I think that your question opens up the need to think about a larger scale cohort where there would be biospecimen collection or access to interrogate that further and more directly. We right now with the available cohorts, at least in the youth, we wouldn't be able to identify increments in clinical outcomes.
I guess the only thing I'd add to that is that while we can use the cohorts and the samples that we have to identify the targets, if we're looking for conditions that are associated with lipid metabolism, we may not need to have bank longitudinal studies to do that. We don't have those really. So could we then look at, if we were to look at folks who were exposed without having their biosamples, we can now ask them questions about those targets to understand, assuming that they had experiences or exposures similar to the people that we were able to measure.
That would be my approach, all right? Because I think that it's been difficult to get funding for large-scale biorepositories. There's also would be issues about how valid that is collected today. So I think, yes, there's definite ability to take a look at people who were exposed at a young age and move forward rather than move backwards.
Yeah, I think we'll have to meet in the middle and do it that way, because I don't see an effective way to work otherwise. But I think with these new tools, we can now ask, we have a way to understand what questions we ought to be asking that we wouldn't know otherwise. And that's what I think is so exciting about the space we're moving into.